Hello, everyone. Welcome to the 2025 Male Infertility Preceptorship by Medea, Medical Education Academy. This is the fourth edition of a successful program devoted to male reproductive health. And this year, we are focusing completely on the new APHRODITE criteria for male infertility diagnosis, prognosis, and management. I'm Sandro Esteves. I will be your host alongside Professor Lynn Antonio, whom I will introduce in just a moment. Today's session is broadcast live from the APHRODITE Clinic in Campinas, Brazil. It is the first of 3 live sessions we are holding this year. So before we dive in, let me introduce Professor Dr. Lynn Antonio. Lynn is an endocrinologist and andrologist at the University Hospitals Leuven, Belgium, and an assistant professor at the Department of Chronic Disease and Metabolism. Her clinical and research work focuses on andrology, reproductive endocrinology, male infertility, and steroid hormone measurements. She is a certified clinical andrologist of the European Academy of Andrology, serving on the guideline and male health awareness committees. And Professor Antonio plays a critical role in developing the APHRODITE criteria, which will be explored in the upcoming live sessions. Welcome, Lynn.
Thank you, Sandro, for this kind introduction. I would also like to extend a warm welcome to everyone joining us today for this preceptorship on male infertility organized by Medea. I have the great pleasure to introduce my co-chair, Sandro Esteves. Sandro is a reproductive urologist specializing in male infertility and assisted reproductive technology. He is the founder and medical director of APHRODITE, a fertility center in Campinas, Brazil, primarily dedicated to male reproductive health. He's also a collaborating professor of urology at the State University of Campinas and an honorary professor of reproductive medicine at Aarhus University in Denmark. Professor Esteves has over 25 years of clinical and academic experience, and he has published over 300 peer-reviewed articles, contributed to numerous book chapters, and authored 12 textbooks. He serves as an associate editor for several journals, including Human Reproduction, Andrology, International Brazilian Journal of Urology, as well as a section editor in Male Infertility for Reproductive Biomedicine Online. He's also the head of the Department of Andrology and the Brazilian Society of Human Reproduction and plays a key role in developing of the APHRODITE criteria. So, Sandro, back to you.
Thank you very much, Lynn. So now I'm happy to give you the official Medea introduction. So I'll just start my slides. Okay, so this program is sponsored by the Medical Education Academy. Medea is a global medical education provider. It is dedicated to developing, implementing, and evaluating medical education programs worldwide to healthcare professionals like all of you. So we have several committees, therapeutic areas in Medea. As you can see in this slide, female and male infertility is one of the main focus. Here you see Female Infertility Committee led by Dr. Robert Fisher with several experts that you might know well. We have also the Male Infertility Committee and other committees as well, like reproductive biology. So we developed these activities along the year, and several programs have been actually accomplished across so many years. So this fourth male infertility educational activity is accredited by the European Accreditation Council for Continuing Medical Education with 2 European CME credits. So you can claim this, CME activities. As I said before, today is the first live preceptorship here in Campinas, Brazil. The second preceptorship will be on April 11 at the Skive Fertility Clinic in Denmark, hosted by Professor Peter Humayden. And the third and last live preceptorship will be on the 3rd of October this year at the University Hospitals in Belgium, led by Professor Lynn Antonio. So we need to know if you like the program and make changes to your clinical practices after attending the workshop. So when we complete this activity, please take 2 minutes to complete a short survey that you see in your screen. And then to receive the certificate. So every activity you can have one certificate, but you need to fill out the post-event survey. This one you receive by email, the link for that. At the end of the workshop, you complete what is asked, and then you get your certificate. So today, as I mentioned before, Professor Antonio and myself will be hosting the session. And from APHRODITE's team, we have Fabiola Bento, our quality manager, who is gonna give you a tour, a virtual tour about our clinic. We have two reproductive urologists who trained with me, Dr. Ackerman and Dr. Viana. They will be discussing cases and then presenting interesting cases about the APHRODITE criteria. Here you can see the faculty disclosures of the participants of today's session. And it's important to say that this program has been developed in partnership with several societies across the globe. So we are very thankful for all the support we have got from these societies in sponsoring, endorsing our program. So like previous years, previous editions of the Male Infertility Preceptorship, this is quite well-attended workshop. This edition, we have 550 participants from many, many countries. So we would like to thank each and all of you for actually registering and attending our workshop. So besides the live sessions, we have a lot of educational material available in the e-learning platform. So we have video lectures. If you haven't watched these video lectures, I invite you to do so. They are available in the e-learning platform. And we also have, a slide kit and open access library with several articles relevant to the APHRODITE criteria that you can download and, check in more detail. So this is like the pre-event materials. So these lectures for you to see, the library. But for the agenda today, we will have, a short lecture about the APHRODITE criteria. After, presenting the virtual tour about APHRODITE clinic. So I will talk about the rationale and the group classification, but you'll have more detail about my talk in the video lecture I mentioned before. This is the first part. And the second part will be dedicated to discussing practical real case scenarios in which we can apply the APHRODITE classification and discuss management of this patient. So, and after that, we conclude our session. But you'll be able to interact with us. So you can submit your questions directly in the chat. So you have, the Q&A box in which you can post your questions during the meeting, anytime, and we'll try to answer all of them if possible, or we can provide answers later on. There is also a chat, the chat room, that you can also chat with us if you have any particular comment. And then we will also have some interactive questions during the presentation, the case presentations, that we will ask you to vote, and then we'll discuss what is actually the results we are obtaining. So with that, I would like to invite Fabiola Bento, our quality manager. She's gonna take us to a quick virtual tour about the APHRODITE clinic. Welcome, Fabiola.
Welcome to APHRODITE, Andrology and Human Reproduction Clinic. My name is Fabiola Bento. I'm the quality manager, and it's my pleasure to be your guide during this virtual visit. APHRODITE is a private clinic founded in 1996. It's located in the city of Campinas in São Paulo State, Brazil. Campinas is the core of a metropolis of 2.6 million people and is the third largest city in the state. It is served by a major international airport and major roads, and is only 90 kilometers from the state's capital, São Paulo. APHRODITE is a standalone fertility center, fully equipped to offer all kinds of fertility treatments. It's also the first ART center in South America to obtain a full ISO 9001 certification. Our facilities include a referral andrology lab and sperm bank, an operating theater for egg collection, hysteroscopies, and male infertility surgeries, 2 IVF labs, as well as cryo rooms. All these areas are certified clean rooms with a centralized air quality control system. A full range of outpatient surgeries are performed in our operating theater, including microsurgical procedures such as varicocele repair, vasovasostomy, vasoepididymostomy, epididymal and testicular sperm retrieval. Hysteroscopies, egg collections, and embryo transfers are also performed in our operating theater. AndroFert has 2 clean room IVF labs that can operate independently. Our labs carry out all kinds of assisted reproductive procedures, including IVF and ICSI, blastocyst culture, pre-implantation genetic biopsy, time-lapse imaging, as well as embryo and egg vitrification and sperm and testicular tissue cryopreservation. Our andrology lab offers basic and advanced semen analysis, including assessment of sperm DNA damage and sperm cryopreservation. AndroFert has many consultants associated with its ART program. The clinic's staff members total around 31 people. Besides providing fertility treatments, AndroFert is also engaged in education. It has trained many national and international doctors and embryologists over the last years. Our clinic has been recognized by the Brazilian National Agency of Sanitary Surveillance as a model fertility center for the last 10 years, and it provides training for the agency's inspectors. Following our commitment with education, AndroFert has partnered with Unicamp, State University of Campinas, one of the top 5 universities in South America. Our partnership is with the Department of Surgery Division of Urology. Senior residents of its urology program rotate in AndroFert as part of their subspecialty training. We also have research collaborations with international centers in the United States, Denmark, and Spain. Together, we have achieved an outstanding scientific production and have become a referral center for male infertility.
So after this virtual visit to the AndroFert clinic, we move on to the presentation of Sandro Esteves. He will give us an introduction to the APHRODITE criteria and guide us through the rationale and the group classification. You can find the full version of this lecture and the other lectures in the e-learning platform. During Sandro's presentation, you can post your questions in the Q&A section so we can address them after the presentation. So Sandro, go ahead.
Thank you very much, Lynn. I hope you can see my screen. So basically, I will provide a concise version of the video lecture I have already recorded. So this presentation, I want to provide you a brief overview about hormonal regulation in spermatogenesis. And then I will explain the APHRODITE criteria, rationale, and how we classify patients according to the new classification. And then I will give you also some information about what we have in terms of evidence on the effectiveness of gonadotropin therapy under the APHRODITE criteria's viewpoint. We need to start by remembering that spermatogenesis is quite an intricate journey. It lasts for about 75 days, and the process is mainly orchestrated by FSH and LH-driven testosterone. So as you know very well, the hypothalamus kicks things off. It releases GnRH, which triggers the pituitary gland to release FSH and LH. And within the testis, It's all about the Sertoli cells responding to FSH and the Leydig cells responding to LH. These cells are crucial players in responding to these gonadotrophies. So if you go now for, looking into specific effects of LH and FSH, LH is critical. It's so important for promoting testosterone synthesis in Leydig cells. So once testosterone is produced, testosterone will find its way to reach the Sertoli cells, where it will bind to androgen receptors. This interaction fine-tunes the gene transcription and prompts the secretion of paracrine signals, which are essential for the spermatogenesis process. So when we think about testosterone, the primary function of testosterone is to promote the development of round spermatids into mature sperm during spermiogenesis, the late stages of spermatogenesis. But testosterone is also important for transition type A to type B spermatogonia, the early stages, and it also upregulates androgen receptor expression. So testosterone gives Sertoli cells a boost in their performance. So now, how about FSH? FSH is critical as well. It acts synergistically with testosterone on the Sertoli cells, and it provides both metabolic and structural support for spermatogenesis. FSH also helps regulate spermatogonia proliferation, also in the early stages. And while FSH might not be the main driver of spermatogenesis completion, this is testosterone, FSH deficiency significantly reduces sperm count, making it an essential part of the spermatogenesis process. Well, in humans, polymorphisms, genetic variations that affect how this hormone works are relatively common. So these genetic variations can influence how LH, FSH, and testosterone function, potentially altering their effects on the Leydig and Sertoli cells. So for many of our male infertility patients, this means that their testicular cells are not getting the right signals if there's a problem with the production or action of FSH and LH. So it's not only about the level that we see FSH and LH, but also the function. And when that happens, spermatogenesis can take a hit. Let's take patients with hypogonadism, for example, a condition in which the testicles are not working optimally. In this man, the Leydig cells don't produce enough testosterone, even when LH levels are normal, which, as we know, directly impacts spermatogenesis. So there are many possible causes of hypogonadism, including congenital or acquired testicular conditions, systemic diseases and infections, genetic abnormalities, aging, obesity, and sometimes, despite all our investigations, we can't pinpoint a clear cause, in which case we call it idiopathic hypogonadism. Despite the fact that optimal gonadotropin production and action, as I said before, are critical for normal spermatogenesis, the potential therapeutic role of hormonal therapy in male infertility remains poorly explored. And there's another problem. Management of male infertility is usually fragmented, with many players involved, which results in a lack of cohesive treatment strategies, high proportion of untreated patients, and use of empirical treatments with suboptimal results. So this biological understanding was key to developing the APHRODITE criteria, which is a new classification system designed to identify infertile men who might benefit from hormonal therapy. APHRODITE is an acronym that stands for Addressing Male Patients with Hypogonadism and or Infertility owing to altered idiopathic testicular function. So the full paper is available as an open access article in the journal RBMO, and the PDF is also available to all of you in the e-learning platform library. So this system was crafted through a collaboration of many experts who were inspired by the Poseidon concept of female infertility. So besides myself, several experts from 5 countries participated, including Professor Lynn Antonio, that are here with us today. So our aim was to address a persistent challenge, the limited progress in the clinical management of men with reduced fertility and reduced spermatogenesis. So this stagnant scenario is frustrating for clinicians like you and me, as well as for patients. So this group of experts believes that the new APHRODITE criteria can provide an urgently needed system to identify and characterize infertility in men seeking paternity, and who are also potential candidates for hormonal treatment. So it's worth noting that these criteria are not applicable to men already diagnosed with infertility due to conditions like varicocele, infection, obstruction, as they wouldn't typically benefit from hormonal therapy. So now, before we dive into the criteria, let me tell you a little bit more about the story behind its name, because if you go for the full acronym, you might think, well, it's a bit complicated, but we wanted to use Greek mythology. In Greek mythology, Aphrodite was the goddess of fertility, male sexuality, and procreation. She was considered the counterpart of Poseidon, a god believed to have influence over female fertility. So interestingly, Poseidon has also made his way into modern medical terminology. A few years ago, we developed the Poseidon criteria, an acronym for a classification system designed for low prognosis women undergoing assisted reproductive technology. So in the world of infertility, Aphrodite and Poseidon serve as counterparts. Poseidon for female infertility and Aphrodite for male infertility. So the Aphrodite criteria have simple key objectives relevant to our male patients. One is to enhance semen quantity and/or quality for those looking for natural conception. And secondly, to enhance semen quantity and/or quality to help make the treatment, IVF ICSI treatment, more successful. So the classification system, Aphrodite classification system, is based on clinical patient descriptions obtained from the medical history and the physical examination, and routine lab tests that every one of us actually apply in clinical practice. It includes basic semen analysis, FSH levels, and total testosterone levels. For semen analysis, we must apply the WHO framework and reference ranges. Patients are classified as having normal or altered semen analysis parameters, including azoospermia. So then FSH levels are grouped as low, normal, or high, based on typical reference ranges that you have in your own laboratory, which may vary depending on the platform used for measuring FSH. In our settings, the normal range for FSH varies from 1.5 to 12 international units per liter, but you need to check your own reference ranges, to make, the clinical decisions. When it comes to testosterone levels, we categorize patients as either normal or reduced, relying on cutoff values outlined in the most pertinent guidelines. One particular critical threshold is set at 350 nanograms per deciliter, which is equivalent to 12 nanomoles per liter. This cutoff serves as the most consensual threshold for identified patients with biochemical hypogonadism. So it means that patients below that threshold is considered as having biochemical hypogonadism. Okay. So when we put all this information together and the relevant clinical patient descriptions, so the patients are stratified into one of 5 different groups. And then we provide suggestions for a unified clinical management using gonadotropin therapy. So the groups are fully characterized, including suggested therapeutic management and relevant treatment endpoints. Let's have a closer look at each group briefly. So in Aphrodite group 1, we are looking at patients with congenital or acquired hypogonadotropic hypogonadism. In simple terms, these patients have a severe hormonal disorder caused by deficient gonadotropin production or action, which prevents their testicles from producing enough sperm and testosterone. These patients typically show low levels of FSH, LH, and testosterone, as well as azoospermia, or less frequently severe oligozoospermia. But here is the silver lining. Gonadotropin replacement therapy using HCG and FSH can work wonders for most individuals in Aphrodite group 1, reviving spermatogenesis. So with the right treatment, these patients stand a solid chance of becoming fathers. So for males with hypo-hypo who wish to achieve biological fatherhood, the primary treatment involves gonadotropins like, especially those with LH activity, such as HCG, either alone or in combination with urinary or recombinant FSH. So the evidence overwhelmingly supports HCG-based therapy as a way to restore spermatogenesis to varying degrees in nearly all patients, with sperm showing up in ejaculate in about 70% of cases on average. Some studies even report up to 100% restoration. However, pregnancy data is inconsistently reported across studies, but some studies report up to 100% pregnancy rate in some couples. Sperm concentration tends to be higher when HCG is combined with FSH rather than HCG monotherapy. And given the cost of long-term gonadotropin therapy, sperm banking should be considered for responsive patients to maximize future reproductive options. So historically, HCG has been the main gonadotropin used to stimulate testosterone production in hypogonadal infertile men. The reason is that HCG structure is similar to LH, so it allows it to bind to the same Leydig cell receptor, but with a longer half-life than LH. So this makes HCG a highly effective replacement of LH for stimulating testosterone synthesis, which is essential for spermatogenesis. HCG has been commercially available for decades, initially extracted from the urine of pregnant women, and more recently, it is produced using recombinant technology. So recombinant LH has also become available in recent years, but its use in male infertility remains uncommon. So it's important to note that exogenous testosterone therapy should never be used in hypogonadal men who are trying to restore fertility, because unlike HCG, testosterone therapy leads to supraphysiological testosterone levels, which will suppress the hypothalamic pituitary gonadal axis, shutting down intratesticular testosterone production, and consequently, it will shut down sperm production. So going back to HCG, when administered subcutaneously or intramuscularly, each dose of HCG triggers a dose-dependent increase in testosterone and estradiol levels, and the peak levels reached around 3 days post-injection. So given this, prolonged effect, when you give HCG twice a week, is typically sufficient to stimulate intratesticular testosterone production. So to maximize the benefits, while avoiding suppression of the hypothalamic pituitary gonadal axis, HCG doses should be carefully titrated to keep testosterone within the supraphysiological range. Additionally, you need to pay attention on estradiol levels that should also be monitored, because excessive conversion of testosterone to estradiol can further suppress the central axis and could negatively impact fertility. So this is just some information important to all groups. But now let's move on to Aphrodite group 2. Here we are primarily looking at a category of patients with idiopathic oligozoospermia and a specific case of non-obstructive azoospermia. Just to refresh, individuals with idiopathic male infertility have abnormal semen analysis, but lack a history of diseases affecting fertility. Additionally, their physical examination lab results are mostly unremarkable. These patients are believed to have functional hypogonadism caused by reduced gonadotropin action, even though their serum levels seem normal. So we have research suggesting that FSH therapy could be a game changer, enhancing semen parameters and boosting pregnancy rates in men with idiopathic oligozoospermia. And this approach may also hold promise for selected cases of idiopathic non-obstructive azoospermia fitting this category. Then we move to APHRODITE group 3, which is basically a variation of group 2. Here, patients showcase, like group 2, abnormal semen analysis parameters and normal FSH levels. The difference is that this group exhibits reduced testosterone levels, indicating biochemical hypogonadism. In this scenario, co-administration of HCG and FSH may offer additional benefits. So, as I explained before, HCG has potent LH activity, so it can boost intratesticular testosterone production and helps stimulate spermatogenesis. So we have also data suggesting that gonadotropin therapy can improve sperm quantity in patients with idiopathic oligospermia and also sperm retrieval rates in patients with non-obstructive azoospermia who fall into APHRODITE group 3. So, for example, FSH therapy has been shown to be effective and is recognized by both the American Urological Association and the American Society for Reproductive Medicine guidelines as a valid treatment option for men with idiopathic infertility. So it has the potential to improve sperm production, improve sperm DNA quality like sperm DNA fragmentation, and even boost pregnancy rates. However, we know that the evidence is still limited. So the optimal treatment regimen remains a topic of debate. And we don't know yet if adding HCG to FSH in group 3 patients offers additional benefit. We clearly need more research to answer these important questions. So this illustration that you can see in the slide shows an algorithm for FSH therapy in men with idiopathic oligospermia. In this illustration, patients with baseline circulating FSH levels below 8 are especially eligible for the treatment because these levels are associated with adequate testicular reserve. So the hormonal treatment relies on FSH for idiopathic oligospermia. I'm talking about specifically these patients, using a dose of 150 international units 3 times a week for at least 4 months. So the main endpoint is to improve the chances of natural pregnancy. And for patients with low testosterone levels, I mean biochemical hypogonadism, APHRODITE group 3, as I said before, low dose HCG twice a week could be prescribed in combination with FSH injections. Now let's move on to APHRODITE group 4. This category primarily includes patients with non-obstructive azoospermia. Usually, these patients display elevated FSH levels and reduced testosterone levels, indicating what we say hypergonadotropic hypogonadism. These are the most difficult patients to treat because they have low testicular reserve, making them similar to the most difficult female infertility patients in the Poseidon classification, which is the group 4 Poseidon patients. But despite the challenges, there are some studies and case series suggesting that when we do treatment, hormonal treatment, primarily using HCG before the sperm retrieval, we could eventually improve the sperm retrieval rates in selected patients. So also providing hope to some patients. So this idea of providing pre-sperm retrieval hormonal stimulation has gained traction, as highlighted in this recent meta-analysis. However, there is an important caveat, which is the significant patient heterogeneity across these studies, making it challenging to draw firm conclusions. This is where precise patient classification like the APHRODITE criteria becomes crucial, because when we classify patients more accurately, we can better identify those most likely to benefit from hormonal therapy and tailor treatments accordingly, like we have shown recently in some studies. So, in fact, there's considerable variation in the hormonal profile of patients with non-obstructive azoospermia. So, according to the APHRODITE criteria, these patients can fall into groups 2, 3, and 4, which highlights just how crucial hormonal assessment is when considering hormonal therapy for patients, that we see in clinical practice. So A one-size-fits-all approach won't work here. Understanding where a patient fits hormonally is key to determining if we can use hormonal stimulation to improve the chance of sperm retrieval success. So now, wrapping up with APHRODITE Group 5, this group comprises patients with unexplained infertility. Taking a closer look from the male perspective, let's recall that patients with unexplained infertility have semen analysis parameters within the normal range, no history of diseases affecting fertility, and normal physical and laboratory findings as well. Now, the notion of employing FSH to stimulate spermatogenesis in this group is based on the fact that in primates, spermatogenesis doesn't run at its highest capacity, and extra FSH may be able to stimulate spermatogenesis beyond its baseline. These patients obviously present a unique challenge because semen analysis, hormonal levels, and physical examination are normal, and their partners' evaluations are also unremarkable, yet they remain infertile for reasons we don't fully understand. As I mentioned earlier, one possible explanation is that from the male standpoint, spermatogenesis in this man isn't operating at full capacity. This raises an important question. Could FSH stimulation help optimize sperm production in this group? Interestingly, both animal and human studies support this idea. And of course, we need much more data actually in this hypothesis that hormonal stimulation could benefit patients with unexplained infertility. However, one thing we do know is that higher sperm counts are linked to a shorter time to natural conception. So this provides a strong theoretical rationale for considering FSH therapy as a way to enhance spermatogenesis, potentially improving fertility outcomes in patients classified as APHRODITE Group 5. So in a nutshell, the APHRODITE criteria provides a precise, structured approach for patient stratification, making communication smoother and more effective among all stakeholders. This innovative system has the potential to streamline patient care, identify specific groups for target interventions, and offer practical benefits for both clinicians and researchers. So beyond that, APHRODITE can help shed light on the prevalence of different patient subgroups, allowing better comparison in the studies in terms of treatments and outcomes. And perhaps even more exciting is the potential to drive new discoveries, whether in pharmacological interventions or even uncovering novel causes of male infertility through in-depth patient analysis. So with that, I conclude my presentation. Thank you all for your attention. And just to take a moment to acknowledge the team we have on AndroFert Clinic, my academic institutions, and my collaborators in Brazil and around the world. Thank you very much.
Thank you, Sandro, for this interesting overview of the APHRODITE criteria. For the audience, if you have any questions, please put them down in the Q&A so we can cover them in this discussion. Sandro, we got some questions about the use of clomiphene, more specifically in APHRODITE Group 2 and 3. Can you give us your opinion?
Well, you know, this selective, this is a very interesting question because we are talking a lot about, you know, gonadotropins, but where we also have historically in the urological field over the years, and you know very well, Lynn, we have been using selective estrogen receptor modulators like clomiphene citrate and also aromatase inhibitors. These molecules, they work actually, they engage the mechanism of actually releasing more endogenous FSH and LH from the pituitary gland. So it's logic to think that, well, if I have a problem with, let's say, functional hypogonadism, I could start, and the FSH levels are normal, in circulating FSH levels are normal, we could perhaps use these molecules to increase, you know, endogenous FSH, LH, and this makes sense. In the literature, we have mixed results in terms of the benefit of, you know, using these these drugs. I believe they can be used as a starting point. We need to check if they are working or not, because in terms of cost, they are less costly than gonadotropins. But one important thing we need to remember is that the polymorphisms with genetic variations I briefly commented in my presentation, in male infertility, as in female infertility, are relatively common. We have some data indicating that patients with oligosospermia, idiopathic oligosospermia, up to 10% of patients, they have what we call genetic polymorphisms affecting FSH, LH, or the receptors. And interestingly, we have some data about azoospermic patients indicating that up to 30%, 30, have these polymorphisms. What this means is that if I boost, the secretion of the endogenous levels of FSH and LH, I might not be able to overcome, the deficiency when it's caused by the genetic polymorphisms. So in clinical practice, we are not testing these polymorphisms routinely, but I believe in future, we might need actually to play a closer look in these polymorphisms as well, to be able to tailor the treatment more effectively. I mean, gonadotropins, or perhaps avoiding starting with tablets that could not work.
Thank you, Sandro. We also got some questions about the choice of the gonadotropin therapy. So question is, do you prefer urinary ACG or recombinant ACG? And for FSH, do you prefer menotropin or recombinant FSH?
Well, basically, I mean, we don't have tail to tail, good comparative studies in terms of the medication. Here at AndroFert, we prefer recombinant gonadotropins. So for recombinant HCG, which is our preference, this is off-label for male infertility. It's important to say that. We have label indication of urinary HCG for hypogonadotropic hypogonadism. For recombinant HCG, we don't, but we like it very much because we use the pen device in which, it's filled by mass. So the protein content is made using recombinant technology, which is very precise. So it's very easy for the clinicians here titrate the dose we need to give our patients. Even small doses, we use clicks using the pen device, or the pre-filled syringe as well. We can split the dose. So our preference for HCG is clear, recombinant. And for FSH, the same. We also, the preference is to use recombinant, FSH, given the same principles of the biological activity. But I mean, the options are available, and everyone needs to check which is more convenient for each particular scenario. Keep in mind that we still need more research to compare these molecules tail to tail.
Following on that, someone also asked, do you see any side effects of using ACG for a longer period of time, a year and a half? And also, how do you check hormone levels during gonadotropin therapy?
Well, this is very important. I think we collected a lot of data in our clinic. We have a recent, paper published in Fertility Sterility, which was the thesis of Dr. Ackerman, that's going to present a case study later on, in which using HCG for quite a long time, we saw, in a population of over 600 patients with azoospermia and biochemical hypogonadism, 30, let's say, adverse effects out of over 600. So most of these adverse effects were related to, some allergic reactions on the injection site or some pain, but not major. We have very few cases of gynecomastia, usually because estradiol levels goes up, that we can control easily by adding aromatase inhibitors. And, these are, in my opinion, and also the experience here, Lynn, and perhaps you can also share yours, is that the side effects are minor. Mm-hmm. And it's very rare that we need to discontinue treatment with HCG even when using treatments for a long period of time. Concerning monitoring, we like to monitor every month. So what we like to do is ask the patient to collect the blood in the morning between 8 a.m. and 10 a.m. to draw, peripheric blood for testosterone, total testosterone measurement, for FSH, LH, estradiol. And we also like to check 17-OHP, 17-hydroxyprogesterone, because this, molecule is a marker for intratesticular testosterone. And then we make adjustments in the dose according to the results we obtain. Importantly, when the patient actually collect the blood, we always ask the patient to collect the blood 2 days after, HCG injection. Because as I said before, the half-life is about 3.5 days. So if you kind of collect the blood too late, you might actually get in the testosterone levels coming down. And you might say, well, I need to increase the dose. So we try to make the interval fixed. And we ask the patients to collect like that 2 days after the injection. You could set your own, method by asking the patient to collect fixed after 1 day or after 3 days. But I mean, you need to keep it fixed, the interval, I believe, to make the clinical decisions when we are adjusting the dose.
Yes, thank you, Sandro. It's very balanced answer, I think. We also got a question regarding making the choice between starting a hormonal treatment in the male or progressing directly to IVF-ICSI in men with oligospermia. How do you deal with that in your clinic? How do you discuss it with your patients? Do you take into account the costs, length of treatment? Can you share your experience on that?
This is very relevant. I mean, we need to individualize case by case. Obviously, there are costs associated with gonadotropin therapy, and we need to take that into the decision-making process. Well, for patients with non-obstructive azoospermia, which is quite common in our clinic, which represents about 18% of our patient population, I tend to propose the gonadotropin therapy before sperm retrieval. Patients with, testosterone levels below 350 nanograms per deciliter. Well, because this is a very particular group of patients in which they might have only one chance. And if we fail in a sperm retrieval, even using the most, advanced technique with the microsurgical sperm retrieval, we might not be able to actually provide these patients another chance. So patients accept very well the idea of boosting testosterone production. They also report improved quality of life, because these hypogonadal patients, they have symptoms, many of them, and we could also, improve the symptoms, hypogonadism symptoms, that makes them more willing to continue the treatment for 3-6 months, sometimes even longer, because we need to adjust. And then for azoospermic patients, quite easily for us to keep the patients on track and, offer the treatment. For patients with idiopathic oligospermia is a different scenario, because we don't have reimbursement in Brazil for gonadotropin therapy. And then we need to, go case by case. If I have a patient in which the semen concentration is not that low, and the couple is willing to, go for natural pregnancy, we discuss gonadotropin therapy with FSH to improve, sperm concentration and also to decrease sperm DNA fragmentation. So we test for sperm DNA fragmentation as well and make this decision case by case. So basically, for azoospermic patients, quite easy to propose, and the patients being on gonadotropin therapy. And idiopathic oligospermia, we have some evidence indicating that we could offer benefit, but we need to discuss case by case. In every country, every clinic, every region will have different policies concerning reimbursements, and they need to discuss that with the patient.
Okay, thank you, Sandro, for this interesting discussion. Also, thanks to the audience for posting all these questions. We are now moving on to the second part of this webinar, where we explore real-world applications of the APHRODITE criteria with 2 case studies. The first one will be presented by Marina Viana. And during her presentation, you can also keep posting questions in the Q&A. So Marina is a reproductive urologist with a specific focus on andrology. And after earning her medical degree, she completed her residency training in general surgery and urology at the University of Campinas in Brazil. She specialized in male fertility under the mentorship of Dr. Esteves at the APHRODITE clinic, and she also went to complete a fellowship in reproductive medicine at the Federal University of Sao Paulo. Since 2023, Marina has been part of the APHRODITE team, dedicating her clinical practice to male reproductive health. So Marina, please go ahead.
Good morning, everybody. It's a very honor to be here today. Thank you, Dr. Sandra, for this opportunity. So today we're going to discuss a case about a 35-year-old azoospermic male with a 31-year-old female partner. They are married for 1 year, no previous pregnancies. She has a normal ovarian reserve, but with PCOS. He has a overall healthy with albeit obese with a BMI of 39. He was a preterm childbirth with a late puberty. In the past, he used GH. He had a complaint about low libido and a perception of low ejaculated volume with no anosmia. That's very important here. At the age of 18, he used testosterone and undecanoate injections every 3 months to induce virilization. He's not using any medication in the time of this appointment. Just a second. So in the physical examination, he had a 5 cc testis, symmetric and soft, with no varicocele, vas deferens palpable bilaterally, no epididymal abnormalities, and normal virilization. So we can see that the testosterone used had a good impact for him. When we looked to the semen analysis, he had multiple samples with azoospermia, with a normal pH and a low ejaculate volume. When we saw his hormonal panel, we could find FSH and LH very low, very above normal range. He had normal estradiol levels, and he had 49 as total testosterone. Dr. Sandra was talking about 17-hydroxyprogesterone, that is an indirect biomarker of intratesticular testosterone. And in this case, we can see that it was very, very low, inferior than 0.1. In genetics, he had a normal karyotype 46XY and no Y chromosome microdeletions. We did a ultrasound image, tested ultrasound. They showed us a normal volume with 5.5 cc in the right side and 5.3 cc on the left side, with no other findings. Normal texture with normal epididymal anatomy, minimal left varicocele, subclinical one. And we also did an MRI that showed marked reduction of adenohypophysis with a pituitary stalk not visualized, and also saw a pseudo-empty cella turcica. That being said, I ask you to vote. What do you think is the diagnosis? Do you think that's, I think the pool is not right? Can you guys confirm for me? That's the second, that's the third question. Thank you. So what is the likely diagnosis? A, obstructive azoospermia. B, pretesticular non-obstructive azoospermia, showing a hypogonadotrophic hypogonadism. Or C, post-testicular obstructive azoospermia, a spermatogenic failure. You can vote. we see the results? I'm not seeing the results yet. Just a moment. Still not seeing. Just the pool. So I think we can continue, maybe. Oh, no, now I can see the results, and most of you marked the pretesticular non-obstructive azoospermia, the hypogonadotropic hypogonadism. So that's the right answer. And that being said, we just saw Dr. Sandro's lecture. What would be his APHRODITE group? Group 1, Group 2, Group 3, or Group 4? You can vote. Can we have the results? So gladly everybody's paying attention. This patient is a Group 1 APHRODITE criteria patient. So let's move on. Just a minute. So to start talking about hypogonadotropic hypogonadism, we have to remember that it's a gonadal failure, as Dr. Sandro said, associated with reduced gametogenesis and reduced gonadal steroid productions due to a reduced gonadotropin production or action failure. It can be congenital as Kalman syndrome and the normosmic hypo-hypo. That's the case of our patient. He had no anosmia, as I said in the beginning of the case study. We can have also the Prader-Willi syndrome. But we can have acquired causes as pituitary surgery, hyperprolactinemia, encephalic trauma, and etc. And we can also have a high idiopathic. The thing is, those patients have LH and FSH levels below the normal range, testosterone levels very low. And when we look to the semen analysis, we can find azoospermia or severe oligospermia. The difference between congenital and acquired hypogonadotropic hypogonadism is based on the deficiency of virilization. We can see that difference between the groups. When we have congenital causes, we have those patients, male patients, with a very deficient virilization. So here we are talking about the APHRODITE group 1, as I said. And as Dr. Sandro showed us in his lecture, we can see a prevalence of 1 to 8,000 men. But here we are talking about only the prevalence of congenital hypo-hypo. We are not measuring the prevalence of acquired because it's unknown. So I will ask you to vote again. What do you think would be the proper treatment for this patient thinking about restoring fertility? I think we can have the answers. People are very fast in voting. So you are all right. So 90% of you vote on FSH or HMG associated with HCG. So let's talk a little bit more about it. Just a moment. Let me get back my control. So what did we do for this patient? We started with recombinant HCG, 6,500 units twice a week. With that baseline hormonal panel we saw, just remembering that, as Dr. Sandro told us, in UNDERFERT we use the recombinant HCG because it's easier for the patient, for storing, and but it's off-label. Urinary HCG is on label for hypo-hypo, but recombinant is not. So after 3 months of treatment, we could see a very good ascending total testosterone curve. He had a 49 total testosterone level, and he went with the HCG to 539, and he was still azoospermic. By that time, we introduced recombinant FSH 150 units twice a week, and we could see FSH levels rising, such as testosterone, total testosterone, and 17-hydroxyprogesterone. When we repeat the hormonal panel, we saw rare sperm with few motile ones, and he had FSH about 0.82. By this time, we uprised the dosage of the recombinant FSH by 225 units twice a week, and we had a very nice result with the semen analysis with 0.3 million per ml and with 33% motile sperms. By that time, ICSI was recommended. Something very important to say, and I think it's better to say now because otherwise I may forget, when we find sperm in those patients, we should recommend cryopreservation, conventional or cell sleeper cryopreservation. And that was what we done. After the sperm outcomes, about 9 months of hormonal treatment, he had 4 samples cryopreserved. So first 3 samples were preserved in the cell sleeper method with 4 vials in sample 1, 3 vials in sample 2, 3 vials in sample C. And in the last sample, we had a conventional freezing. That was the best sample he had, thinking about concentration. And the ICSI outcome is here in your screen. The wife had 22 metaphysi 2 oocytes retrieved. 19 were fertilized. That was a very nice rate of fertilization, 86%. After that, they had 13 blastocysts that were cryopreserved, very, very good quality blastocysts. And they had 2 transfers. So the first one was a single transference that was negative. And the second one had a very nice result with a singleton healthy male infant delivered. So I brought here today the article we recently published in Andrology. It's a review article where we talk about the human chorionic gonadotrophin-based clinical treatments for infertile men with non-obstructive azoospermia. Here I'm going to talk only about the pretesticular causes, the hypo-hypo. So we had 50 studies with more than 2,000 patients. It was compounded by mostly case series. The thing is, there was a very high heterogeneity in regimens and dosages, but the preferred approach was HCG monotherapy or its combination with urinary gonadotropins, HMG, FSH, or recombinant FSH. What was the main finding? So HCG associated with FSH combination therapy is recommended, particularly in congenital cases. HCG is used in a dosage of 1,000 to 2,500 twice a week units when we are talking about the recombinant one. FSH was used in a dosage of 150 to 225 units, 2 to 3 times weekly. The thing about this treatment is its duration that has to be a little bit longer, up to 18 months. And the results we can see is that it will restore spermatogenesis in up to 100% of patients, the average about 70% with sperm in the ejaculated. HCG monotherapy may restore spermatogenesis in adult onset hypo-hypo. Maybe in those cases with congenital causes, it's better to associate with FSH therapy, sorry. The adverse effects, as Dr. Sandro told us, they are very rare, and we could find gynecomastia, acne, injection site reactions as pain. The other important thing to say is that we have to monitor those patients very closely with regular hormone testing and semen analysis, and we have to recommend sperm banking for responsive patients all the time, conventional methods or cell sleeper. Pregnancy data is still inconsistently reported in existing studies, and the effect of recombinant LH on hypo infertile males not yet evaluated. The challenges we have here is the high variability of patients' populations, as I said, and the protocols, and further research needed to establish optimal and personalized therapies. This is the pathway that the HCG works, as Dr. Sandro told us. So it's very similar to the LH, but with a higher half-life that help us. And the take-home messages here are that gonadotropin therapy effectively revives spermatogenesis in most APHRODITE group 1 patients, offering a strong chance of fatherhood naturally or via reproductive therapy. Sperm count usually higher with HCG combined with FSH versus HCG in monotherapy, but as I said, studies comparing different drugs and regimens are very limited, and we can still study more about protocols to find the optimal one. Treatment duration is typically long, requiring follow-up with hormone testing, semen analysis, and this can be an expensive treatment depending in where you are. And sperm banking is recommended for patients who respond to therapy. Last but not least, what you should never do in APHRODITE group 1 patients desiring fertility. First thing, prescribing exogenous testosterone therapy. This will inhibit all the systems, so all the axes. So that's forbidden for all patients actually desiring fertility. You should never perform surgical sperm retrieval in untreated hypo men. And you should never perform sperm retrieval in patients taking testosterone or shortly after cessation. You should never prescribe gonadotropin therapy without a proper follow-up. That's because even both under physiological and supraphysiological testosterone levels will be detrimental to spermatogenesis restoration. And last, prescribe aromatase inhibitor or SERMs. Because given the intrinsic hypothalamic or pituitary dysfunction, the mechanism of action of those drugs cannot be engaged. So that's not a very good idea. Thank you very much.
Thank you, Marina, for presenting this very interesting case. We have some time for questions, so if you have any questions, please put them in the Q&A. We got a first question regarding the age of the wife and then considering egg freezing or not. Would you say, well, we start hormonal treatment in the male, we wait for months and months to get the spermatogenesis going before, and we then do the oocyte retrieval, or would you suggest to do egg freezing in some cases? Could you discuss that?
Well, I think that should be discussed with the gynecologist we all together, but we know that waiting 6 months to go to ICSI, it won't alter the reserve of the ovarian. So we could wait to go to the ICSI with fresh eggs. But if we have a woman with a very low reserve in the beginning, we can suggest egg freezing.
Another question that came up during Sandro's presentation is also, how long do you treat with gonadotropin therapy? Also, when there's no sperm in the ejaculate, when do you decide to go to surgical sperm retrieval? Could you comment on that in view of the case you presented?
Yes, so as we said, the hormonal treatment is a bit longer. You can see better results with 6 to 9 months of hormonal therapy, but that's very individualized for each patient. That's why we have to do a very close monitorization of hormonal panel. In our practice, we usually keep an eye in the FSH levels and testosterone levels. And when we reach optimal levels, and that being said, it would be testosterone levels higher than 400 and FSH levels higher than maybe 4 to 5. I think Dr. Sandro can explain it better. that's the proper time to go through a sperm retrieval surgery. We shouldn't do it with FSH levels below 1.2, 1.6. That wouldn't be the best scenario.
Yeah, if I can just compliment on that. Well, I think you need to think about the duration of spermatogenesis, as I said before, because the duration is about 3 months. So every time you make an intervention, you need to wait at least 3 months. So if you are okay with if the monitoring shows optimal results of FSH and testosterone, and you are more than 3 months on that, treatment regimen, and there's no sperm in the ejaculate, don't do it too early. I would say before 6 months, we never do. We want to optimize the results. There are some patients in which we treat for about 1 year. So when we are confident that the FSH, testosterone levels, forget about LH because we are giving HCG. So HCG will make LH very low. So don't bother about LH. The only important thing about LH when we monitor is to make like a quality control that patients are taking HCG correctly, not in the congenital hypo, but in other cases, because we know that if the patient takes HCG correctly, LH goes down. But anyway, if you are confident that for about 6 months, the patient is with optimal levels and there's no sperm in the ejaculate, I think it's sound to consider surgical sperm retrieval.
Okay, thank you. I also saw in the case that you do follow-up of estradiol and 17-hydroxyprogesterone levels. Could you give us some clinical guidance on that for people that are not doing it at the moment? How should they start doing it? What are interesting things to look at? How do you handle these measurements in the clinic?
So I think 17 hydroxyprogesterone, it's more a thing for us to keep following during the hormonal modulation, not to look it isolated in the first hormonal exam. When we see it uprising with testosterone levels, we can understand that we are having a better intratesticular testosterone. And the estradiol will help us see especially testosterone estradiol rates. We have to keep it above 10. That's it.
I think, Lynn, perhaps you can also comment on that. For us, we started doing 17-OHP some time ago. It gained some attention in urological literature. What we see here is that there's a good, relationship between total testosterone and 17-OHP in non-obese patients.
Mm-hmm.
So I think when you are giving HCG therapy, sometimes the patient is obese. And when you monitor, you are not very happy with the testosterone levels you get. You say, okay, I think I'm thinking about increasing the dose. And then if you go for 17-OHP, and if it's like, the minimum should be around 50 nanograms per deciliter according to data we are collecting. But if I see a patient in which the testosterone levels is below 350, and the 17-OHP is like above 100, so most likely the testicle is making a good job in terms of producing intratesticular testosterone. The issue is more related to obesity. And then we are collecting the blood in the periphery and making the assessment of total testosterone. You can also go for free testosterone, but 17-OHP for us is like, reassuring that we are in a good path in terms of the HCG therapy.
Yeah. Yes, indeed, in obesity, it's important to also look at my preference is to look at SHBG and free testosterone, but you can indeed also take into account the 17-OHP concentrations. I think to really implement it in clinic, it would be good to have some more data in literature about it to really know to get more information in which patient groups it's interesting to follow it up, what level we need to get in our patients when we start treatment with gonadotropins. But it's really, yeah, also looking at the profile of the patient that you are treating, and not only looking at the hormone levels. Yeah.
So one thing that, if I may, about estradiol levels, because I know that there are some questions about that. So every time we give HCG therapy, we boost intratesticular testosterone production. I mean, 95% of testosterone we have in the body comes from the testicle, 95%. So when I boost intratesticular testosterone production, it will translate into testosterone levels we can measure in the periphery. So then we measure usually, typically, total testosterone. Because this circadian rhythm, we should measure in the morning between like 8, 10 a.m. This is like according to the guidelines. This is important. And the other thing is that it's expected that estradiol levels will go up because part of testosterone will be converted into estradiol by the enzyme aromatase, especially in the adipose tissue. So you give HCG, you will boost testosterone levels. You need to expect that estradiol levels are going up. However, some patients, they have polymorphisms of aromatase enzyme, and they convert too much, or they are obese, they convert more. So these high estradiol levels could also inhibit the hypothalamic pituitary axis and could be a negative effect. So what we do, we consider the ratio between total testosterone in nanograms per deciliter divided by estradiol picograms per ml. You need to make conversion in these units to use the ratio, the cutoff of 10. Cutoff of 10 only works when you kind of measure or you need to transform testosterone in nanograms per deciliter, estradiol picograms per ml. So we need 10 times more testosterone than estradiol. So let's say a patient with 500 testosterone nanograms per deciliter and 40 estradiol picograms per ml. And before it was 15 estradiol, and you say, well, it climbed from 15 to 40. You add aromatase inhibitor to kind of block this conversion. Well, you don't need to do that because the ratio is still above 10. So, I mean, I believe it's important to control, but we are not very, enthusiastic about giving aromatase inhibitors for patients. And when we give aromatase inhibitors, we give very low dose because when the estradiol levels goes down, one adverse effect is low libido. And they complain, some patients complain of erectile dysfunction. So you need to be very careful, actually, when, at least in our hands, we are very careful when we are prescribing aromatase inhibitors.
Okay, thank you. We will now proceed to the second case. This will be presented by Dr. Arnold Akkerman. Dr. Akkerman is a reproductive urologist who has been part of the AndroFert clinic since 2020. And like Marina, he also completed his urology residency at the University of Campinas in Brazil and has specialized in male infertility under the mentorship of Dr. Esteves. Arnold recently earned a master's degree also in surgical pathophysiology from the University of Campinas, where he did his thesis, and this was focused on hormonal stimulation before sperm retrieval in men with non-obstructive azoospermia. He has published 16 papers in total, and 8 came from his thesis work, which is very impressive, I think. And it was published in journals like Fertility and Sterility, FNS Reports, and Andrology. So, Dr. Akkerman, I look forward to hearing your case.
Thank you so much for the kind presentation. Hello, everyone. I'm Arnold Akkerman. It's a pleasure to be here today. I'd like to start by thanking the organizers for this opportunity to share a fascinating case we treated at AndroFert Clinic. Just trying to have the access. Yeah, so here, let's start. This is a case of a 46-year-old azoospermic man with a 2-year history of primary infertility, and his 34-year-old wife has an unremarkable clinical evaluation performed by a gynecologist specializing in infertility. He is otherwise healthy, but has a history of aortic valve insufficiency treated with a valve replacement, which requires a long-term anticoagulation, warfarin and ASA. He underwent a bilateral microdissection testicular sperm extraction, mitral TESE, more than 10 years ago elsewhere. At that time, no sperm were found in the left testis, and only where abnormal sperm cells were retrieved from the right testis, deemed insufficient for ICSI. Histopathology showed pure Sertoli cell only in both testes. On physical exam, both tests were symmetric, soft, and hypertrophic, measuring roughly 10 cc in volume each, and both vas deferens were palpable, and there was no clinical apparent varicocele. A scrotal ultrasound confirmed testicular volumes of 10 cc and 8 cc with no microtesis, but detected a subclinical left varicocele. Hormone testing was normal, except for the low total testosterone levels according to the APHRODITE criteria. Pay attention that this fact of the criteria of APHRODITE to tell us that it's low levels, because the cutoff of APHRODITE criteria is lower than 350 nanograms per deciliter. The FSH levels in the upper normal limits and the low 17-hydroxyprogesterone levels. Genetic tests revealed a normal karyotype with no Y chromosome mictulations. So here's my first question in this case, and I'd like to participate and vote. What type of azoospermia does this patient have? Obstructive azoospermia, pretesticular non-obstructive azoospermia with tropic hypogonadism, or post-testicular non-obstructive azoospermia with somatogenic failure? Nice. The majority of people answered correctly. The post-testicular non-obstructive azoospermia with somatogenic failure. We will talk more later about this then. So, just me trying to follow. Yes. Now, my second question in this case, in which APHRODITE group does this patient fit? Group 1, Group 2, Group 3, or Group 4? Please choose an answer. Yeah. So here, the majority of people answered the Group 2, but we're going to talk more about this now. Just 50% answer Group 2 and 30% answer Group 3. Let me continue. So, answering the last question, our patient had azoospermia, FSH levels with the normal range, although in the upper normal limit, and reduced total testosterone levels 12 in nanomole per liter. So please remember that APHRODITE group 3 patients showcase abnormal semen analysis parameters, including azoospermia, FSH levels in the normal range, and reduced total testosterone levels, indicating biochemical hypogonadism. In this scenario, HCG, which has a potent LH activity, has been suggested either alone or in combination with FSH, as it may boost intratesticular testosterone production and help stimulate spermatogenesis. Talk about my third question here. Would you consider homotherapy pre-sperm retrieval in this patient? No and why, or yes and why? Please choose an answer. nice, interesting. I think this meeting is achieving the goal. Had the majority of people FSH2. So 54% choose yes, letter E with HCG alone or in combination with FSH if needed. So let's continue the case. So let's talk about our protocol. At Underfert Clinic, the stimulation protocol for cases like this relies on HCG therapy. And before treatment starts, patients sign an informed consent form as a gonadotropin therapy in such case is off-label. So we begin with recombinant HCG, typically 2080 international units, administered twice weekly. And patients undergo monthly hormone evaluation, and we adjust the regimen as needed to maintain the total testosterone levels between 350 to 900 nanograms per deciliter. If FSH levels drop below 1.5, we introduce 150 international units of recombinant FSH 3 times a week. And if the testosterone to estradiol ratio falls below 10, we add an aromatase inhibitor. Our preference is anastrozole, 1 milligram daily. And we reach 3 months of hormone stimulation. We include semen analysis in the follow-up. Typically, we continue the treatment for about 6 months. And if any viable sperm are detected in the ejaculate during the follow-up, they are preserved. If azoospermia persists, we proceed with microtesting. So we start in this case with HCG with 2080 international units per injection, which correspond to 8 clicks of the recombinant HCG pen twice a week. And in the 3-month follow-up, the semen analysis showed azoospermia, and the home assessment showed an increase in both total testosterone and 17-hydroxyprogesterone. It is worth mentioning that 17-HCG is a marker of intratesticular testosterone. So based on this remarkable increase in the 17-hydroxyprogesterone levels, it was clear that HCG therapy was able to boost intratesticular testosterone, translating into improved serum levels of total testosterone. The increase of total testosterone levels resulted in a negative central feedback, resetting the FSH levels. However, the FSH levels dropped too much to below 1.5. And to fix this, we added recombinant FSH at 150 international units 3 times a week while keeping the same HCG dose. And at the 6-month follow-up, the semen analysis remained azoospermia, and the hormone profile was deemed adequate. Please note that the endogenous LH levels are suppressed, as Dr. Sandro already told us. And when HCG therapy is given, and when HCG replaces the LH activity, so this is not a problem of these low levels of LH. So the next step here in this case, as remained azoospermia, was sperm retrieval. In our clinic, the method of choice to retrieve sperm in men with non-obstructive azoospermia is microtesting. And we started with the right testis, which had a slightly larger size than the left one. Intraoperatively, most seminiferous tubules appeared thin and high analyzed, as you can see this image in our left-hand side. And however, we could identify a few clear areas of enlarged tubules. These tubules were extracted and sent to the IVF lab. The largest tubule's diameter was 250 micrometers, which is a good size for finding sperm according to our data. And indeed, in this case, mature sperm were retrieved, so some of which were motile, as you can see in this video in our right-hand side. So, to estimate, sorry. Yeah, the amount of tissue extracted in this case was adequate to allow freezing 8 separate specimens, 4 of which using the conventional cryopreservation technique and 4 by vitrification, with the cell sleeper technique. And to estimate the minimum number of metaphase 2 oocyte needed to have at least one euploid blastocyst for transfer, we use the ART calculator, recently rebranded as one oocyte number estimator, which is freely available on the Merck Group website. This is a predictive model developed at APHRODITE, which has been validated in a multi-center and multinational study to estimate the optimal number of oocytes needed to improve the success of IVF. And the calculator estimates the number of oocytes needed based on two main factors: the woman's age and the type and source of sperm. So, through the original calculator study, we learned that using testicular sperm from men with non-obstructive azoospermia raises the number of oocytes needed to obtain at least one euploid blastocyst for transfer compared to ejaculated sperm. For this particular couple, the calculator indicated we'd need about 10 mature oocytes, confidence intervals between 7 and 12, to achieve at least one euploid blastocyst. And to increase our chances of hitting this target, we used a GnRH antagonist protocol with recombinant FSH and gave a dual trigger for final oocyte maturation. So 8 mature oocytes were retrieved and 6 fertilized using frozen followed testicular sperm, resulting in 5 high-quality blastocysts. And after PGTA, 2 of those 5 were found to be euploid. With that in hand, we scheduled a single embryo transfer, which resulted in an ongoing pregnancy. So, this case illustrates the potential use of the pre-sperm retrieval hormone stimulation with exogenous gonadotropins in azoospermic patients fitting APHRODITE group 3. With this in mind, I would like to comment a few points here. And first, the prevalence of patients with non-obstructive azoospermia according to the APHRODITE criteria. In a recent study of more than 700 non-obstructive azoospermic patients, we found that nearly 40% fell into APHRODITE group 3, which is defined by normal FSH levels, but biochemical hypogonadism. Classifying these patients according to the hormone profile is crucial, as the sperm retrieval rates vary among them. In our study, we saw that eugonadal non-obstructive azoospermic patients, I mean, those with normal total testosterone levels, had significantly higher sperm retrieval rate compared to hypogonadal patients, particularly when the FSH levels were within the normal range. Importantly, among hypogonadal non-obstructive azoospermic patients, I mean those with reduced total testosterone levels lower than 350 nanograms per deciliter, patients with normal FSH levels, that is lower than 12 international units per liter, normal gonadotropic, had notably better sperm retrieval rates than those who were hypergonadotropic, with FSH levels over than 12. So, concerning the role of hormone therapy, we looked into our data of over 600 patients with non-obstructive azoospermia and biochemical hypogonadism undergoing microtesting over a period of 7 years. In this research published recently in Fertility and Sterility, all patients had baseline total testosterone levels lower than 350 nanograms per deciliter and no previous sperm retrieval history. Sperm retrieval rates were compared between patients receiving or not hormone stimulation according to the protocol I've shown you earlier. And we also performed a multivariable logistic regression analysis to investigate the associations between the patient's variables and the microtest success. So what did we find? We found that pre-sperm retrieval hormone therapy was the strongest predictor of success with microtesting. In fact, the sperm retrieval rates were significantly higher in patients who received hormone treatments compared to those who did not. We also looked into the role of the baseline FSH levels on sperm retrieval outcomes in patients who received hormone therapy. For this, we divided the cohort into 2 groups. those with FSH levels within the normal range, normal gonadotropic, and those with the elevated FSH levels, that is over than 12 international units hypergonadotropic. So after adjusting the relevant factors, we found that the patients with normal FSH who received homotherapy had significantly higher sperm retrieval success than those with high FSH levels. So what does this tell us? For patients with low testosterone but normal FSH levels, in other words, APHRODITE group 3, boosting endogenous testosterone with HCG therapy may help stimulate spermatogenesis and improve their chances of sperm retrieval. And what about the sperm retrieval technique for non-obstructive azoospermic men? In our hands, we go with microsurgery, and indeed, the literature shows that microtesting optimizes sperm retrieval success in men with non-obstructive azoospermia. The chances of finding sperm are twice as high as TESA and 1.5 higher than conventional TESI. These findings are based on studies directly comparing these techniques tail to tail. So that brings us to the end of my presentation. And now let's go to the key takeaways. Okay, so first, non-obstructive azoospermia is one of the toughest challenges in male infertility, but it's not the same as sterility. In fact, nearly half of men with non-obstructive azoospermia still have some levels of sperm production inside the testes. Intratesticular testosterone is the key to spermatogenesis. And we know that hypogonadism is common in men with non-obstructive azoospermia. Interestingly, men with normal testosterone levels tend to have higher sperm retrieval rates than those with low testosterone. That's where gonadotropin therapy comes in. It aims to boost intratesticular testosterone and potentially improve sperm production and retrieval rates. However, it's important to acknowledge that the evidence is still limited, and we don't yet have strong data comparing different treatments, protocol, and durations. And finally, sperm retrieval is just one piece of the puzzle. The best results come from a team effort, bringing together reproductive urologists, embryologists, and fertility specialists. So a multidisciplinary approach, it's what truly makes the difference in helping couples achieve their fertility goals. Thank you so much. Thank you for your attention and opportunity.
Thank you, Dr. Ackerman, for this very interesting case presentation. For the audience, you can still post questions about the presentation of Dr. Ackerman in the Q&A session. The first interesting question that came up is what do you think about treating a varicocele in men with non-obstructive azoospermia?
Good question. Here, the special thing you must pay attention of talking about varicocele, if it's a clinical varicocele. We know that varicocele, if it's clinical, it will benefit, especially if the grade that you have. If you have grade 3, it's the most benefit that the patient may have sperms in the ejaculate after 3-6 months after the surgery. So if it's relevant, the varicocele, if it's palpable, clinical, and group grade 2 and 3, it's a benefit. And in this study that we published together and I already talk about, we evaluated that treating varicocele, its benefit, it's significant variable to help and have achieved higher sperm retrieval rates. So if in summary, if it's clinical and grade 2 and 3, it's good to do the surgery before the microtesting if it's needed.
And how much time do you wait between treating the varicocele and doing the sperm retrieval?
Yeah, at least 3 months. But we know we have literature talking about the best moment. It's between 6 to 7 months after the surgery. We can get 2 cycles at least of spermatogenesis, but we must take care of the time that we have talking about the couple with the woman. It's with old with the age and the ovarian reserve, maybe at least 3 months. Okay. And
Lynn,
we
can I
can
jump
do it
in?
together.
Can I jump in for the varicocele, which is very interesting question? So this study Arnold presented that we published in Fertility Sterility, basically the title was like clinical factors impacting microdissection testicular sperm extraction success in men with non-obstructive azoospermia with biochemical hypogonadism, basically APHRODITE groups 3 and 4. So it was very interesting for us to see that in the logistic regression analysis, when we made models including all clinical variables, although pre-sperm retrieval hormonal modulation pop up as the most important one, also significant relevant factors were having a clinical varicocele was a negative factor, and having a history of previous varicocelectomy a positive factor. Not so strong as others, but I mean, this indicates, and it's in agreement with some observational studies we have in the literature. We don't have RCTs on that, but some observational studies showing that. So I think we need more data, especially from prospective trials, RCTs, but if we consider the potential negative effect of varicocele, clinical varicocele, we mean, because we are talking about varicocele that we can identify in the physical examination, that could harm the testicle in terms of several pathophysiology mechanisms we know. And just interesting, you know, the first case report of a varicocele in the literature, so, I mean, dozens of years ago, was a doctor reporting a case in his own son. And the kid was a azoospermic patient. And the doctor did varicocelectomy on that patient, and he started to have some sperm in the ejaculate. So we have reports even showing that varicocelectomy can improve, you know, spermatogenesis. Some gynecologists are very reluctant with varicocelectomy, and we see here many colleagues, when we discuss varicocelectomy with our patients, they say, well, the gynecologist said it doesn't work. And sometimes they see worsening in semen parameters. So what I say is that with all medical interventions, surgical interventions, we need to be very accurate. And I think for varicocele repair, there are many options like open procedures and microsurgical procedures, laparoscopy, embolization. But in our hands, we go with microsurgery because we can see better the veins. We do a subinguinal approach in which we identify the veins. We use intraoperative Doppler ultrasound to identify the artery. Sometimes it's more than one. So we can spare the artery, we can spare the lymphatic vessels, making, I believe, the procedure accurate in the sense of they are providing, you know, good treatment for the patient. So some considerations for the varicocele are important. I don't think all patients are eligible. We need to see case by case because the findings are that we have in the literature and in our own study were based on retrospective analysis, but still, I think something worth considering.
Okay, thank you, Sandro. This made me also think about the choice of using a micro-TZ in NOAH patients. You have the possibility to do micro-TZ in all your patients. Do you have any advice for people that don't have any very good access to micro-TZ? If they have to choose between one of the other sperm retrieval techniques, how can you optimize it? What would be your choice if you don't have a micro-TZ at hand in your center?
I think if you don't have the expertise to perform the microtesting, at least you must optimize as much as you can with the clinic factors that we talked about, like is the hormone profile, if you can give some medications, depending on case by case that this webinar, we want to show the benefits of hormone optimization and corrective hormone profile. So it's one thing that you can optimize. And the second is the varicocele. Other things, it's the clinic factors, like we know it's much the better the health of the man, the better the fertility. So like weight loss, lose weight, sorry, to stop smoking, talk about many factors that we know that damage the fertility. So as you know, the male fertility, and you improve the fertility of this man, you can reach the highest chances to retrieve sperm. We know that talking about types of surgery, microtest is the best one, but if you can at least optimize the fertility of this man, it's the best opportunity that you have.
Mm-hmm.
I think this is very relevant. I think that Arnold said about the lifestyle, improving the overall health, like obesity, you know, it's associated with hypogonadism, low testosterone levels, smoking, etc. This is quite relevant. The guidelines indicate that the best approach is microsurgical approach because we can see better. We can scan the full testicle. It's obviously, you know, providing a better chance. If you don't have the settings for doing that, the next, you know, the next step would be to use open testicular sperm extraction, and basically try to do it taking samples from different parts of the testicle, perhaps doing, you know, 3, 4, 5, 6 different places. Not aspiration, because testicular sperm aspiration is, according to the studies directly comparing these techniques, they show twice as lower than microtesting. But the most important message, Lynn, I think, is that if you have a patient in which you have done, you know, what you have in hands, like the conventional testicular sperm extraction, the patient comes with Sertoli cell only, well, we need to be cautious not to close the door, because as you see in this case, this patient, he had a previous, you know, sperm retrieval elsewhere, in which the histopathology showed Sertoli cell only. I mean, this is just a picture of the testicle. The histopathology is not able to show the testicle as a whole because there is heterogeneity in these seminiferous tumors. So if the patient comes with a report in our hands after a conventional testing with a, you know, negative, even when it's Sertoli cell only, obviously we use this information to do counseling, say, well, your chances are low, the prognosis is reduced, but still there is in our hands 20% chance of finding sperm in case like that. I mean, previous negative, and, you know, even with the most severe histopathology results. This is important information, I think, that doctors need to keep in mind.
Okay, thank you, Sandro. Also, thank you for all the participants to posting questions in the Q&A. I think we have had a very interesting discussion. I would like to thank you all for your participation, and we go back to Sandro to make some concluding remarks for today.
So thank you very much, Lynn, for, you know, coordinating all the case discussions, the questions, everything. So obviously, I would like to thank the faculty, Marina, Arnold, and you, of course, and each and everyone who take the time out to be here with us today. So it was wonderful. I think we had many participants staying with us until the end. Also, the support that we have from Medea, because obviously organizing a webinar like that's not easy. We need to thank Medea, especially Chloe and Alessandro. They are in the background helping us to organize all the things. So they made this webinar possible. So I would like to remind everyone that participants will receive an email with a survey link after the session. This link is important for you to complete to receive your certificate, the CME certificate. And also after we finish, I ask you to stay online for a few minutes to fill the survey with some questions that are important for us organizers to help us measure the webinar's educational impact and what we can do to improve, you know, next sections. Also, it's important to tell you that the recording of this session will be available on the Medea website. So the e-learning platform will launch and you'll be informed when the recordings are available. And I want to, encourage you to save the date. The next webinar is gonna be April 11. It's gonna be the second live session on this 2025 male infertility preceptorship, which will be hosted at the Skive Fertility Clinic in Denmark by Professor Humaid and his team. So I hope to see you all there. Reach out to us if you have any questions. And thank you very much for being with us today. With that, I would like to conclude this webinar and wishing you very nice weekend. Take care and see you soon. Goodbye.
Bye-bye.
Bye-bye. Thank you.
Bye-bye. Thank you very much.